long and arduous search for something. And, I was wondering whether Google is trying to tell us something because, in India, in many industries, the promise of what is possible and the achievements of reality, there's always, this big gap. But, the health insurance sector has been different. It has, driven growth in excess of 35%. But still, when you look at it in terms of what we need to accomplish as a country to make sure that everyone has health protection, the gap between where we stand today and where we need to get to make sure that we have the ability to make quality healthcare accessible to all, there is still, maybe 500, 600 million Indians who need health protection. And that's really the topic of today's panel discussion. And who better to deliberate and give ideas on this other than the three leaders we have on the panel? Dr. Prakash, the MD of Star Health, Anthony, the CEO of Apollo 24/7, and Mayank, the CEO of Aditya Birla Health Insurance. All three gentlemen who've been driving gravity-defying growth in many ways. And really, I'd like to break this discussion into two parts. One is, if we have to bring, let me say for a moment, 1 billion Indians under health insurance, my question to each of the panelists, starting with you, Anthony, is what do you think needs to be done in 3 years if we have to move from, depending on who's counting and what's the definition, maybe 450 million Indians who have some form of health protection as we stand, to 1 billion Indians in 3 years. What do you think we need to do? What is it? What is the transformation that we need to accomplish collectively to get there?
Yeah. Thank you, Krishnan. And thank you, CII, for putting this together and inviting me to be a panel. Always a pleasure. Before I get into what I think is required or the changes which India needs to go through, I just thought it would be interesting to put some statistics out and then set the context for what needs to be done. Out-of-pocket expenses, which was about 74% of the total healthcare spend in 2001, has come down, and that's credit to the insurance schemes, the government schemes as in the private sector. It's down to 62, but still extremely high by any standards. Comparable countries which are worse than us, just two, best of my knowledge, Bangladesh and Venezuela. Even our neighbors, Pakistan is better at about 60 or 59. So we do have a severe problem in terms of out-of-pocket expenses which are being incurred. And to put some context in terms of the spends, the percentage of spend on GDP, healthcare spend on GDP is still at about 1%. If you look at countries like South Africa, it's at about 8%. And more developed countries like Germany, it's about 11%. The real issues on the ground, as I see it, which needs to be tackled hand in hand with financing schemes like insurance, is how do we make up for the shortage of hospital beds and doctors? Hospital beds are 0.9 per thousand in India. Physicians are 0.8 per thousand. In terms of the quality of healthcare, my statistics suggest that there's over 2.5 million people who die every year because of poor quality healthcare. And even where there is healthcare, it's heavily skewed towards, the cities. Although population is 65% rural, the healthcare facilities are only about 20-25%. So to me, health insurance is one. There's a bigger issue which we have to address is the current lack of healthcare infrastructure and healthcare professionals in the country. So there are two things which need to go hand in hand. One is the government needs to firstly invest much more than what they're doing today in healthcare. And as I said, it's just under 1% or 1% of GDP. It needs to go up. It needs to support the creation of infrastructure both in the public sector and in the private sector. It needs to welcome private sector participation beyond the big cities. It needs to create more capacity for medical professionals, incentivize people to take these and get on to it. And along with this, the insurance industry needs to play a big role. The progress over the last 10, 15 years has been quite good. If you look at it from a CAGR point of view, which would be about 20% CAGR. But while looking at it on a standalone basis, it looks interesting. I think the fact is there is an opportunity to grow at a much faster pace. There's an opportunity to grow much wider into the geographies, apart from participating in government schemes like Aayushman Bharat and various things. So, and there are the right moves have been made. Aayushman Bharat is a good move. The private sector is doing well in terms of raising awareness of health insurance. The recent standardization of the standard product is a welcome move in that direction. The COVID cover is a good one. I think there are some encouraging signs as I see it in terms of expanding the reach of insurance and growing the 500, as you said, to a billion, and from there on to 1.3 billion. But it has to go hand in hand with the creation of healthcare infrastructure. So I think there is a big role for the government to play, and there is an equally big role for private sector to play. And I do believe it needs to go hand in hand. You're on mute.
Thank you, Anthony. I'll come back with you with a couple of follow-ups, but before that, I'm interested to hear from Dr. Prakash.
Hello, am I audible, Krish?
Yes.
So it's a very challenging thing that how we are going to expand the volumes to 1 billion. A digital transformation is happening. More volunteers are willing to work as advisors in the health insurance sector. Hospitals are also showing a lot of interest, and they are becoming indirectly they are becoming advocates of health insurance business. But still, with all that, I do not know how long we are going to take to reach this 1 billion coverage. One important thing, I just wanted to suggest, maybe most of the other things people already know. Are we spending more on intermediary cost and less on paying claims? Is one important question we should ask ourselves. Health insurance can grow only when we start paying for claims. By word of mouth, the concept of insurance and the confidence of people, the trust and confidence of the people on the insurance sectors, if it has to grow in multiple folds, we should be looking at the incidence and severity, where out of 100 people who pay for health insurance currently, close to 7 people get benefits. How can we increase the benefit so that there are more people who are benefited and through word of mouth we can expand the health insurance coverage? But if that has to happen, Mr. Anthony was talking about out-of-pocket expenses coming down from 74 to 62%. But most of the out-of-pocket expenses are due to OPD, diagnostics, investigations, pharmacy, and other things. It is not only the inpatient charges. So I think, we have to leapfrog and enter into the coverage of outpatient segments so that the severity and incidence can increase and more people can have the benefit of a health insurance. And by word of mouth, we can penetrate faster. So that's one thing what I want to add apart from most of what all of us know, and all of us are very eager to watch this transition. And digital and technology is, I'm sure they are going to play a very great role. And now, National Digital Health Mission, which has been started, where they're trying to do a digital health stack. I think these things are going to reform and help insurers to penetrate faster. Missing the middle is another concept where there is going to be a subsidized, insurance cover for people in the bracket of 72,000 to 5 lakh. So with this and with the current expansion that is happening in the affordable segment, I think that we should reach this 1 billion cover, whatever, Krishnan envisages. I think it should happen in the very near future. We will closely work on it, Krish.
Thank you, Dr. Prakash. Mayank?
Yeah, thanks, Krishnan and CI for this, for the invite. And, I think two of my very esteemed co-panelists have already shared, some the relevant perspective. What I might say might actually be re-emphasizing some of the observation that Anthony and Dr. Prakash have made. Let me try and cover this through three dimensions. One is the whole idea of insuring, and the other one is to reduce the underinsurance, and the third is, also these are two on the demand side, and the third quickly I like to talk about is the supply side issue, because supply side on the healthcare is very closely linked to making sure that the demand also increases, which of course will create a larger awareness and need for health insurance products. So clearly, the way I see the blueprint emerging in India is that if we divide the 1.35 odd billion population of the country, the Aayushman Bharat is clearly looking at catering to a particular size of the population, and my sense is that will increase slightly beyond what was originally envisaged, because some states are looking at expanding the scope to cover people beyond the traditionally defined people under the Aayushman Bharat scheme. Plus, as we start putting the similar norms for all the other government schemes, whatever it might reach to, let's say about 650, 700 million people. The private sector, in any case, is catering to people who supposedly can afford, who have, demonstrated, an ability to pay. And so today it is close to about, I guess, 120, 130 million people who are covered there, right? So the issue is, how do you cover the population in between, which Dr. Prakash referred to as a missing middle? I'm excited at the discussion that are going on, through the NHA and the industry bodies and IRDA, where now we are talking about leveraging the whole Aayushman Bharat infrastructure, the healthcare infrastructure that has been created, to see with existing products, including products like the Aayushman, the Arogya Sanjeevani and other standard products that can come in. Now, how can we find a way to actually make affordable offerings for that missing middle, which typically starts beyond the Aayushman Bharat coverage, and as it moves towards a set of people who are in any case have an ability to pay the full price. So broadly, I see that as the contour of how we will get there, and I think the base platform that has been created through Aayushman Bharat, the healthcare infrastructure, the technology layer, and the work that is happening around that, I'm very excited with that, because that will be leveraged by all other form of insurance as well, including the traditional private insurance that has been growing well. But the other side is also about underinsurance, right? Because if we talk about the total healthcare spend, and if 60% of that is outpatient, and more importantly, if you have to cover the entire continuum of healthcare expenditure, then we have to find a way to get that in. And again, I'm excited there because digital health and the advent and the adoption of digital health, which COVID has actually precipitated and in some way amplified, I think that can become a huge, I would say, turbocharger to the adoption and the ability to bring in those range of healthcare expenditure into the fold of insurance, discretionary or otherwise, which ultimately will make the product more relevant and more wholesome for consumers to explore it, because many consumers today do feel that I don't see myself in the hospital and I may not get a benefit. As Dr. Prakash said, if 7 out of 100 are getting, the balance 93 are wondering why did they pay the premium, right? Where if you get the larger healthcare expenditure into the fold, then of course it starts becoming more and more relevant. And it's also relevant for health insurance because now you are interacting and engaging with consumers for the entire continuum. And therefore, there's an element of gatekeeping, awareness of the full healthcare need of the consumer and so on and so forth. Right? So I think that's how I see we can get to the 1 billion that you spoke about, Krishnan. But the only last point I want to make is it's extremely critical that the supply side, which is the healthcare, the entire delivery mechanism has also got to get expand to across the country, because finally if the service delivery is not there, then it will come in the way of the adoption of health insurance products. And again, I feel excited because I was yesterday, I was listening to someone and he was saying that the usage of tier 2 tier 3 hospital has suddenly increased in more COVID times because people are more willing to use those facilities. Now if trends like those continue and the demand increases there, and the ability of healthcare industry also to invest in the smaller and the far-flung towns increases, then I think the overall both supply and demand side will actually help grow along on the same side, and hopefully create the right enablers for the insurance category. So those will be my initial thoughts, Krishnan.
Thank you, Mayank. I mean, all three of you made very relevant, very pertinent points. But look, if I added up all of your suggestions, I'm still not seeing us getting to 1 billion in 3 years. So I'm going to push some more on the same theme. And I'll go back to you, Anthony. If there is one suggestion that you have to make, whether it's mandating health insurance or anything else that will truly transform from where we are to adding another 500 million Indians, what do we really need to do? If, for example, this group came back and saying, look, if we did this one thing which can be truly transformational, what would that one thing be? Because all of what I heard is necessary, it's important, but at least in my opinion, it doesn't get us to adding another 500 million people, which perhaps there's an opportunity for us to reset and look at things dramatically differently. Because all said and done, the industry it's been growing well, it's been doing well, but it's incremental to what we have to accomplish as a country. So I'm really looking for something that's truly out of the box, and something that maybe will not fly in normal times, but we are in extraordinary times. So I'm going to ask each of you again for something that's that we could do that's dramatically different from what we've been doing so far. So Anthony, Dr. Prakash, and you, Mayank, I'm going to ask this one more time to each of you.
Yeah, there's no magic solution out here in terms of getting to 1 billion. The closest I can think of is for us to recognize, as Dr. Prakash put his numbers, said that the big component of the out-of-pocket today, which is 62%, the big component, substantial portion of that 62, I'm not sure whether it's 50 or 50 out of the 62 or what, but a big component of that is outpatient. And I think the need of the hour is for us as an industry, both healthcare and insurance industry, together to come and crack this one big one. The first step in that direction would be for the government to recognize that outpatient products developed by health insurance companies is different from an IP, indemnity based product for hospitalization, and take that GST, which is currently at 18%, and bring it to zero, or bring it close to zero. Over the last few years, I'm aware that a number of companies, health insurance companies, have tried to develop outpatient product, but I believe that this 18% was a significant contributor in it not being a success, because a person walking in to a diagnostic center or to a doctor clinic doesn't pay 18% GST on that diagnostic test or consulting fee. But if it is through an insurance, the person would need to pay 18%. So the first step is to recognize that it's needed. It will substantially boost the insurance coverage. People need it. So that's from the government side. The other side is the insurance industry and the healthcare industry putting their heads together. I am quite optimistic, given what I've seen in the last 1 year in the on the e-health side in terms of telemedicine and teleconsultations, and the work which is happening on the digital space. I do believe we are very, very close to actually designing a product which will be a win-win for all, the customer, the insurance company, and the healthcare provider. So that's what I would say in terms of a big opportunity for us to crack. There needs to be an intervention by the government and the regulator and the healthcare and insurance industry.
Thank you, Anthony. Dr. Prakash, if there's one thing that you would ask Anuradha to take to, whether it's the regulator or the health ministry or the finance ministry, what is that one suggestion from your side? Or are you with Anthony that there is no magic bullet?
I do agree that there is no magic bullet, but if Anuradha gives me that option, I'll only say one thing. Let us look into the model of those countries who have successfully adapted to universal healthcare. Because I recall as a medical student doing community medicine in 1987, I read about health for all in 2000. We thought that by 2000 we will achieve health for all. But 2020, where we are, we all understand. So let us look into the model of a country which is successful in implementing universal healthcare like Japan. Although they have most aged people, they are able to achieve that because the single most important factor is they are able to implement uniform fee schedule. So standardization of cost. In India, healthcare practices are very differential and healthcare architecture is very fragile. Do we have a uniform training? Are all the specialists and doctors competent? And do we have a proper monitoring mechanism? Or in one word, is there a regulator for the hospitals? And do we have a standardization of cost? If Anuradha wants to ask me one choice, which I want from the government, please create a regulator for hospitals and work towards standardization of cost in the hospitals. This is going to help not only insurance customers, but the public at large. Take, for instance, the same COVID-19 scenario. I should really, say that we are very grateful to those of our doctors who are anesthetists or a pulmonologist or infectious disease doctors who are working 8 to 10 hours a day doing a rounds and spending their time amidst COVID-19 patients and saving their lives. They are up to date with what is the current treatment because there are a lot of uncertainties on management of COVID-19. But they are very clear in what stage they should intervene, who are those moderate to severe patients, what is the intervention, what is happening in the international European side where they are able to save patients who are in the ICU or who have gone to the ventilator, what can be the best practice to emulate. People are working on it and saving life. We have to be very, very grateful to this segment of people. But this segment of people, I believe all of us know, they contribute a very small percentage. In spite of the life-saving efforts that is happening in the healthcare space, we read the newspapers, we watch the media, and in our own personal experience, we see in our day-to-day life in health insurance as we handle claims. A good portion of our hospitals, unfortunately, they're charging heavily for an asymptomatic or a mild symptomatic patient who doesn't otherwise require an admission. And how are we going to control it? How are we going to create a standardization of procedures? What are those patients who require a repeat investigation? How much can we cap for a professional charge? Investigations, diagnostics, room rents, which patient really requires an ICU or an isolation ward? Is it really an ICU or a what converted into an ICU. So there are a lot of things, which needs a proper, I think, technology should play a very great role to capture the right information that is available in the hospital, bring in transparency in the operation, and then slowly I think the government should leapfrog and introduce standardization of cost. We are talking about standardization of cost for decades. And when there is a pandemic, where all of us are together and we are trying to fight this pandemic, we are not able to achieve standardization in COVID-19 cost. When we are not able to achieve this during this pandemic, or how much are we close towards achieving a standardization in general and then reaching your 1 billion cover? My friend Mayank was talking about close to 0.5 billion covered by Aayushman Bharat. Is it an adequate coverage? Health insurance universal coverage means, we have to look into prevention, primary care, and specialty services. Prevention and primary care are state subjects. Okay, to cover the specialty where today the supply-demand mismatch in government hospitals and the prohibitive cost in private hospital, wanted the government to come up with a scheme like Aayushman Bharat, where there is a public-private partnership, where they are taking the help of private hospitals. Do all those high-end quality private hospitals participating in this scheme? And what is the level of benefits that are being enjoyed by the people? We wanted a scheme to help a person to have a cardiac disease or cancer disease or a renal transplant to be addressed, not the mere hernia or piles. So we'll have to look into those things and understand the ground reality, and really, the epicenter here is a customer or a common man. I think we have a lot to address on these things, but one thing, Krishnan has given you only one option. I can ask only one thing. So one thing what I can ask is, please do something on standardizing the cost and procedures. If that requires a regulator, that will be my one ask.
Thank you, Dr. Prakash. That was both your passion and your pain speaking. And Anuradha, you do have one suggestion. Mayank, any further thoughts? I have a couple of questions from our audience as well, but any further thoughts specifically on what can we do that could really transform health insurance penetration in our country?
Krishnan, if we have to be practical about all the ground realities, as Dr. Prakash was sharing passionately, and what Antony was sharing, then yeah, I think the only practical way, to my mind, is to make some form of mandate in and create some fiscal benefit which actually makes it practically meaningful for the Indian population. Because I think everything else has its own journey. The fact that health is not a centrally governed subject, so making and we all whilst we can all hope, it has its own challenges in implementing what ideally we would want. So I would say to start with a mandate, some form of mandate. And how do we define that population where it should be mandate? For example, corporates can be mandated that this benefit has to be given, right? I mean, that itself can certainly increase the size of population covered. So that is there. But again, I'll just repeat what Antony and Dr. Prakash said about the coverage, the full range of coverage. And I think one thing that regulation can allow to increase the scope of coverage and making the product more relevant, which I feel will have a cascading effect in adoption, is to allow health savings account concept to be launched by health insurance companies to cover the entire outpatient. Because in the current form of what is allowed, I feel that even if they were to reduce the tax to from 18 to lower level, I feel it may not still serve the purpose, because structurally there's an element of discretion there, and it has to be that consumers will have to apply discretion, and it will have to be through a fund product and not necessarily a full insurance product. So, and it is very, very practically being implemented across different part of the world. And I don't see why in India we should not allow that, because you suddenly take off the cost of tax, as Antony said, which hopefully government will allow, but also the cost of distribution. You can have a very differential cost of this, and then of course the digital health infrastructure will hopefully enable us to offer that. So I would say these 2 points, Krishnan.
Thank you, Mayank. And I think you touched upon a journey that a few companies have gone down the road of. I mean, the United States, for example, what they refer to as Obamacare, which the Trump administration is trying to dismantle. does go down the road of individual mandates, they have achieved some success because I think the number of uninsured in the United States, for example, has fallen from about 40 million odd when Obamacare was launched to about 20 million or so today. So I just want to quickly follow up with that question to Dr. Prakash and Anthony. And mandate does have its minuses. Clearly, from a private sector standpoint, whenever we ask for sovereign intervention, it will come with rules, restrictions, aspects around pricing, affordability, etc., etc. So, quick reactions from you, Dr. Prakash and Anthony, on Mayank's point on, should we go down the route of a mandate to achieve universal health insurance penetration in India? Anthony, you're on mute.
Yeah. So, see, mandate could work for corporates, and you could define corporates. And it could be the whole lot of corporates, or you could define a certain segment of corporates. I think it would work, but mandating every person in this country to have is something which is going to be extremely difficult. And I think for that to happen, you've got to demonstrate, the government needs to demonstrate there is adequate quality healthcare available for people. And without that, I think that needs to come in first before mandating every citizen of India to have health insurance. So I do see a problem in mandating the public, but I see a case for mandating corporates.
You're on mute,
Krish, a small add-on to what Mr. Anthony said. We can mandate the corporates to have a cover itself. Is there any? Yeah. Is there any voice disturbance? Am I audible?
We can hear you, Dr. Prakash.
Yeah, Krish. So we can mandate the corporates to have a cover for themselves, and also at beyond a level, each one of them can sponsor for someone who cannot afford. In that way, the corporate affordable educated people can stand as a testimony and an example for others. So mandating, I agree to Mayank, mandating is to achieve something, but there are people who do not have food, cloth and shelter. How can they graduate to health insurance? So I think, we are paying a huge tax. In fact, I would prefer mandating beyond a point, whatever this, the salary scale. Based on that, we can mandate people to sponsor. Each one of them can sponsor one or two based on their salary scale who cannot afford. In that way, you are mandating it not only for me, but also through me. You want me to cover two more people. In that way, I think if every corporate employee earning more than 88,000 per month, I'm told that 10% of the Indian population have that. The 10% they start sponsoring each two policyholder. Probably, this 10% may become 30%. That can be one way where we can, but I do not know. The implementation requires a lot of, technology and assistance, but we can give a thought to that.
No, and in some sense, the social insurance works on the basis of what you just described, Dr. Prakash. Quite an interesting discussion, and there's a very interesting, intriguing question from one of the members in the audience, and the point really, and this is again up for discussion, and I'm interested to hear your opinions. Is in terms of what is the path to universal healthcare access in India? Traditionally, government has been in the business of creating supply. Of course, we have private healthcare delivery starting from the mid 80s, and Apollo, has been a pioneer in that. And then with the launch of some of the, the government schemes, there's been lots of discussion around demand side, creating demand for delivery, and delivery will follow demand, to the point that many of you are making, that look, we don't have a health infrastructure. There is thinking that says that if you put money in the hands of people, demand will create its own supply. And of course, globally, there is the UK model, and there is the US model, where in the UK model there is, and indeed in a lot of European countries, you have fairly widespread social insurance, and private insurance kicks in as supplementary or complementary to that. And there's the United States model, where for most part, the aged and the poor are addressed by government, and the rest of it is led to the private sector. So if we, just in terms of a macro choice, on what's the right model for India, interested to get your opinions on, in terms, as we talk about a path, ultimately it is about making healthcare accessible. What's the opinion of each of you? And again, I start with you, Anthony. Anthony, you're on mute.
So my view here is that we should have our own model, which is in the sense that we have an issue in terms of affordability of a huge percentage of our population, which is 30-40% of our population still needs assistance, financial assistance. There is a layer of people who are just above that income bracket. And what has been designed today in Aayushman Bharat, I think, is a great design. As somebody earlier said, is that adequate enough to ensure that healthcare is available for the people who need it, who are coming under this cover? They perhaps not, because going back to the same topic, we don't have the necessary infrastructure. Along with this, for people who can afford it, I believe it should be, through schemes like private health insurance, which is what is playing out today. For the people above the 500 million who are covered by Aayushman Bharat, have a choice of going to any of the private or public sector companies and buying an insurance. And I think in terms of the model as it is, I think it should be allowed to continue, and I think it will take its own course before we come to the 1 billion. We've got to fill in a number of or build a number of pillars to come to the 1 billion. But the structure, as I see it today, is adequate.
Hi, Krish.
Yes, Dr. Prakash.
Yeah, Krishnan. So I have to compliment the government in this context on two initiatives: the National Digital Health Mission and the Blueprint for EHR and DigiDoc. Really, it's I was so thrilled to know about it. In fact, they're trying to create the idea of missing middle is also a very good initiative. And I think all insurers are in support of this initiative. And I think, this is really going to help the common people. More important than that, I heard about the health exchange that they want to introduce. That's going to be a very good initiative for this country to achieve UHC. See, setting up of this health exchange to service the mass market, that is, they can shop, individuals can shop and enroll an affordable medical insurance that can fit their purse. This marketplace can be made available, or they can be accessible through a website or call center or an in-person assistance. So these health exchanges, missing the middle, all these initiatives are really something which every one of us have to support, and it is going to create a win-win-win for stakeholders in the ecosystem.
Thank you, Dr. Prakash.
So, Krishna, I think we've already taken the step to what our model is going to be, and I think we have to build on that. Because I don't think so, we can now look at something completely different from the model that we have looked at it. And clearly, if I, in the Indian population, if we divide them into three segments, there's a segment which just cannot afford. There's a segment which probably can partially afford, and then people who can afford it fully, right? And the government has taken a call that, the segment which cannot afford we'll go the full government funded model, the social model where, it's funding out of whatever, its own fiscal, purse. And now if you have to take it beyond that, then we'll have to find a way of subsidizing some of the segment above that, through either very simple get into the funding kind of some offering which is subsidized, standardized, and meeting the basic requirements. And that again, someone will have to fund the subsidy, right? I mean, and who will fund the subsidy? Finally, we'll have to find a way of finding the taxpayers to fund the subsidy, because ultimately that's where the government will get the money from. But what is important is that every rupee of that funding that is going is actually being is spent in the right manner, which again goes to the point that is the supply side being governed and managed in a certain way, whether the cost is being spent in an efficient manner. There's, as you know, the amount of fraud, waste, and abuse that happens today, or whatever, 10-15%, that's being reduced. We are getting the benefit of volume of in the cost, etc. So I think whilst in the COVID case, whilst we can say that the cost is not standard, but I think one thing has definitely emerged, as I talk to different parts in the medical fraternity, is that the standardization of the treatment definitely has come in. So everyone is being treated in the same manner, whether he's in the government hospital or whether he's in the most the highest ward of the private hospital. Now that is one step towards standardizing cost, right? That the treatment protocol is standard, and I think this is something that can be evolved. So which will itself be bring the cost down. So the model has to be full. I think the Aayushman Bharat model, the Aayushman Bharat Plus model of subsidized or standard products with the population above that, and then the fully people who are finding a way to fully fund themselves. My reference to the mandate was more towards the people who can afford, and there is an affordability through the right incentive to kind of make it mandate for them. Of course, people who cannot afford, there's no point. I mean, what's the point of mandating, right? And then making sure that the supply side is being governed in a manner that the cost is being done most efficiently. So in a way, something similar, a combination of NHS kind of model for some part of the population, and the US model, but not making the mistake that the US healthcare model did of making the cost so prohibitive, which cannot then which a country like India cannot afford. So it has to be an element of dealing with the demand and supply both parallelly, because then only you can really find something which is sustainable.
Well, thank you, Mayank. Quite insightful. All three of you, I must say, at least I'm personally enjoying this discussion. One other question that we have from our audience, and this speaks to points that each of you made in some form or fashion, that look, to reach the missing middle, we've got to figure out how we increase awareness, and awareness not in a very facetious way, but awareness in a way that builds trust. And of course there's a number of things that we need to do. And I take this question to you, Mayank, because I know that you've been leading an initiative from the industry side to increase awareness. Our equivalent of the mutual fund Sahi Hai campaign, so to speak. Where is that, and what else can we do to really increase awareness and build trust in insurance?
Yeah. So, Krishnan, you made a very valid point that awareness is not just creating some ads and etc. Right? Awareness is much bigger, and because awareness is also about creating the relevance. So I broadly talk about awareness in three different aspects, and I'll come. One is just in the form that we talk about, right? That just people are aware that there is something called health insurance, and this is what it does. The second one related to that is also to make sure that there is a relevance, that consumers find the offering relevant for them. Because even if I know that yes, there is an offering, if I don't find relevance, if I don't connect to it, then there's no way I'm going to kind of look at it, and I'm not going to explore it. And if I'm deciding to explore it, then is it giving me the experience that I wanted, and which will ultimately create the trust that we want, which then will through a process of people knowing that yes, this offering can actually deliver what the category is promising about. So I think all three aspects have to be catered to at the same time of just making people know about our offering, the whole range of benefit that it gives, what does it do, making the product offering relevant, and therefore designing products and offering. I mean, you see what has happened to Corona Kavach right now, right? Suddenly the a simple product has caught the attention of such a large mass of population in a short period of time, because suddenly people felt there was enough awareness because of the environment. People saw that there is relevance because I needed it at this point of time. And of course, I think the industry has really done a fantastic job in delivering the experience. When the claim has happened, they've gone out of the way. And I think this is what is required at a holistic level to really create that awareness. Now, talking of the industry program, I think it's in the process. I think we are still it's the first leg. We all have to be together in it. It's in, as you said, it's an industry, so it's not about one, two, three companies who can finally make it work. It's everyone's conviction that yes, this is the right way to go. And I think we have enough reason to believe that this will be successful, given the fact that there's low penetration and also the success of what mutual fund Sahi has done. So we'll have to put our heads together, see what we have seen. Unfortunately, the COVID happened in the period, so there had to be some adjustments to the whole initiative, which is happening. And I think the council is looking at it on a ongoing basis. But if you ask my personal opinion, I think we should continue with the effort, but cover three aspects. So of what I just mentioned.
Thank you, Mayank. So I want to pick up a theme which you mentioned, and also.
Question, can I just add to what Mayank just said?
Yes, Anthony, please.
Yeah, see, one big reason why people, the trust factor is not there is people hear about claims which are not paid, and people do not hear and do not want to hear in terms of, do not have a source to hear in terms of the amount this industry has been doing for the people, right? So two things. One is, can CII, and Anuradha, this is for you, can CII together with Ministry of Health or come up and publish a healthcare cost index so that people know how the costs in healthcare are going up and down. And this is particularly important when new products and pricing, etc., changes. People are aware that this is happening because of the healthcare inflation. I think that's something which is overdue. And it would be great if CII could work with the ministry, and it needs to have blessings of the ministry. If again, if people need to trust this and use this in terms of a variety of things. Second thing is, why not the council publish every month, ideally every day, on real-time basis. Every day it should publish the total claims paid in every state in this country. You could start it off on a month on month, and bring it to a week, and who knows, when if you have technology which if you can put on a daily basis a little box in one of the key pages of the newspaper. This is what the industry has paid state-wise. Maharashtra, Tamil Nadu, Jammu and Kashmir, whatever it is. Let people come to know that this industry pays about 50,000 crores worth of claims. I think people don't understand. If you take a dipstick survey, people do not understand that this industry pays this much. In fact, it pays much more than own damage. So I think apart from having these TV ads, which are great, by the way, Modi and Sachin make an excellent pair, and maybe we should borrow the same pair. The health industry, apart from doing all of that, I think needs to make public a lot of the good which it's doing.
No, spot on suggestion. Spot on, Anthony. I think your suggestion, giving publicity to claims that are getting paid, I think it's an excellent one. And I'm sure Mayank, Dr. Prakash, or I will take that up. I think it's an excellent suggestion, because the perception is that the industry doesn't pay claims. The reality is that in some parts of our business, we pay out more in claims than we take in premiums. So I think we do collectively have a role in correcting that perception. We have a few minutes left, and I just want to come back to, we do have a few questions from our audience, but I just want to, in the interest of rounding off the discussion that we started, and on the theme of awareness, if you sort of layer awareness, one of the points which all of you made is, look, maybe people don't see enough value in this product because only 7 on 100 or 6 on 100 end up using the product. And all of you mentioned that maybe outpatient is the way to go to make the product more tangible. So coming to you, Anthony, digital health has taken off dramatically, specifically, since you took charge at Apollo 24/7. Do you want to talk to us about your experience in where digital health is going in India, and specifically, if you have some ask from the health insurance industry so that we can embed that in a very relevant way, to Mayank's point, into our products, what do we need to do? You're on mute, Anthony.
Yeah, digital health has really come a long way from where it started. And just to put into context of how I see it in the next 5 years, if about 40 billion US dollars is the total healthcare spent today in India, today's digital health is in the region of about 0.8 billion. I see this moving rapidly over the next 5 years. While the total healthcare spend is going to increase by about 10-15% year on year, I see digital health growing at about 75% CAGR. This 0.8 billion, I see it moving close to 8 to 10 billion by 2025. And healthcare spend will be at that point of time about 70 billion. So this is just to give a feel in terms of the speed at which things are happening. But I can tell you that digital health was always well accepted by people, but the healthcare industry had not yet adopted it pre-COVID days. But thanks to COVID and the tailwind which we have got, we've seen a huge adoption. Just to give some of our own figures, we've seen registered users of over 4 million in 5 months. We are seeing week-on-week growth of about 10%. And I believe that this is there to stay, and it's not just us, and I'm sure all of our competitors and everybody who's there on the digital platform in the healthcare business is seeing significant growth in the right direction. And I believe that now the healthcare side of the equation, the doctors and the consultants have all adopted it. They didn't have a choice in the month of May and June, but they're loving it. They're seeing that this is an opportunity to do a number of things very differently. Access to them is much easier. Quality is better because what can be done on video is done on video, and then time, when it's more complicated, there's more time spent in the consulting rooms. The cost of delivery becomes cheaper. Preventive care, personalized care, consumer convenience, better patient outcomes, connected relationships with providers, and improved patient adherence is all what we are seeing in the last 5 months. And all of this is very, very good news for the healthcare and health insurance industry. You asked specifically in terms of if there was an ask. I do believe there's, and I said this right at the beginning, that the one thing which had evaded all of us in the healthcare health insurance industry is an outpatient product. And I think with digital health, a lot of the blockers, a lot of the issues or the challenges which we all had in the past is going away. Digital health is a very, very transparent process. It's recorded in most cases. It is all available for scrutiny, and this makes it much, much easier for the pricing actuaries to actually come up with a good equation in terms of pricing outpatient products. I'm personally bullish that from the delivery side for outpatient, from the delivery side, the e-health platforms are well equipped, and we need to really work together with insurance companies to see how we can actually give out a product which is catering to outpatients. So my ask is let's work together and use the experience of digital health to come up with their innovative solution for outpatients.
Anuradha, we have time for one last question to Dr. Prakash. So, Dr. Prakash, you made this point early on around outpatient, but the fact also remains that there is one point of view that health insurance is inflationary for healthcare. And with outpatient, we know there are a number of challenges. So, did you have a specific segment in mind when you said outpatient, specific services in mind, or what is your definition of outpatient, and what do you want? What would you want to see in an insurance offering?
Krish, it should be outpatient, should be a coverage not only for consultation facilities. It is not what I mean as going to a doctor for a sprain or for a fever to a general practitioner. Those things people can manage. What I want to look at as outpatient is consultation to a specialist or a super specialist, which invariably involves some investigation and a huge pharmacy bill. So that should be an outpatient coverage which should be able to take care of the consultation, diagnostic charges, and pharmacy bills. And this requires a very strong IT platform, IT integration, as Mr. Anthony was pointing out. And as you rightly said, we have to make the premium very attractive because here the strike rate is going to be very high. And again, we need a very strong IT platform to network doctors who are at the level of specialty, super specialists. These people have to be networked so that the claims journey should be very seamless. They need not come for an approval, and it should be online, automatic approval and validation of PED, whatever has to be done. We have to create a strong system, network specialists and super specialists, introduce initially for specialty consultation, and add on relevant charges for investigation and pharmacy. In that way, outpatient products with outpatient coverage will be seeing a very bright light in the near future.
Thank you, Dr. Prakash. I'm afraid that's all we have time for. So I do want to thank you, Anthony and Mayank, for your very interesting and very insightful comments. The takeaway for me is that we have an evolutionary answer as opposed to a revolutionary answer to healthcare. But within that evolution, I'm hearing that there are a number of mini revolutions that we will need to make happen. And as we discussed yesterday, this is an ecosystem industry, so clearly we need collective action if we have to move towards the promise of healthcare for all. Thank you very much for your time and your comments. Thank you.
Thank you, Krishnan. Thank you, Anuradha.
Thank you, Dr. Prakash.
Thank you.
Thank you.
Thank you. Thank you, everybody.
Thank you. I take leave, Anuradha. Thank you.
Hi, Mr. Jain. Arijit this side from CII.
Yeah, Manoj Jain here from Sriram Life, Arijit.
So we're just going to run some advertisements. So meanwhile, request everyone to be on mute.
Hi, Mr. Jain.
Hi, Manoj. Ashwin Singh on this side.
Hi,
Okay,
Radha.
Hi, Anuradha.
Hello. Hi.
and Manoj here.
Hi. Manoj.
Ashish, hi. Can't hear you.
Hi,
Hi,
Gunjan.
Gunjan.
Good to see you.
Hi. Good to see you. Good to see you.
Yeah.
So we're live right now.
Oh, yeah? Okay.
Okay.
Hello, everyone. Welcome.
Hi, Saket. Good to see you.
Good to see you, Anuradha. I joined some other link, so I was texting you. So, hi,
we are,
Manu. Great to see you.
yeah,
Hi,
we just
Saket.
start.
Hi.
I just speak to Randeep also.
Yeah. So I see all the other panelists are here, so it's great.
Yeah. Yeah, Saket.
So welcome all of you.
Yeah.
I can't see Yashish for some reason. Let me.
So, Saket, what will be the flow of event? You will be starting questions that 1, 2, 3, 4, 5. That's the way to work, or what? I think we are live. Just see whether we are live.
We are live, Manoj.
Oh,
So
okay. Fine. Okay. Okay.
what we're going to do is, since you asked the question, we will start with you.
No, no. No, there are a lot of other people are there. So I'm only from insurance company. So let the people to have other flavor first. People may be sick of hearing the insurance guys. So and that to life insurance guys.
See, as the only insurer on this panel, you have to lay the foundation, and after that we'll go to the others.
But you have a lot of white hair now. Yeah? Yesterday also I saw you. What's your age?
Actually, Manoj, sitting in this lockdown, I think has created it.
Acha. Good. Yeah.
So we're just waiting for Yashish, Manoj. I'll just go back to him.
Fine.